are any of you using embolization EPDs during these interventions, like a spider or NAV6, or have you gone away from using a embolization protection device? Omar?
So I used to use an embolization protection device when I was using Jetstream for like a long segment occlusion, ISR type case. But I have not had an issue with Rotarex with like a bad distal embolization complication. And I would say I've probably done over like 50 or something, and I haven't had any issues with Rotarex with ISR, treating like ISR or something like that. Obviously, and so I don't use a filter. I feel like sometimes filter can cause complications themselves or things like that. You know, you try to, and it takes a lot of time. So, I mean, I personally don't use filter devices, but I do have techniques. Like if I do see distal emboli, you know, I have some stuff in my lab where I can go and try to aspirate it out or something like that. So that's what I do. That's what I do. So
I think that's one of the benefits. I mean, again, this is not a Rotarex, commercial or anything, but I think that's been a very great addition to the atherectomy market here. Srini, you mentioned you use a lot of laser. When I was doing laser for ISR, I actually had a couple embolizations. And then I started using an EPD. Is that just operator failing, or is that something you do? I don't know the right answer.
No, I mean, again, we all know this. I mean, all these devices have problems of some type in terms of distal embolization. Again, the percentage is small, but it's real and it's there, and it can be catastrophic, as we all know. I think what's made a big difference, and I misspoke previously, but the Rotarex has aspiration ability regardless of the size, I think, right, Omar?
Mm-hmm. Yeah.
Is it all the catheters?
There's like a 6.
Or is it just a large? I think it's the larger ones, right? There's the larger two sizes, I thought. I can't remember offhand, but we'll have to look that up.
I think there's just two sizes. I think both of them do.
They both do. Okay. So with laser, obviously the Philips laser has no aspiration ability. I have seen distal embo with that, especially with ISR. I'm not so sure it's the laser causing the embo. I think it's you laser and you have that goopy stuff that's in the lumen. You do an angioplasty and it embolizes distally. So people always recommended run it multiple times through there to kind of remove as much of that and vaporize as much as you can. I think with the angiodynamics laser, in that case, the larger catheters have aspiration ability. So that adds another, safety component when you're using it. As far as distal protection devices, I'm kind of in Omar's camp. If they have really poor runoff, I'll start thinking about it. If I have a long segment occlusion or a heavily diseased calcified vessel, I'll think about it as well. There's one paper out of Mount Sinai, New York. I think it was the Prakash Krishna and his group. I think it might have been 1,000+ patients. I can't remember offhand, but they basically came up with an algorithm based on the plaque, how much calcified it was and so forth, of when you should use a distal protection device. So that's an interesting paper that they wrote. But again, this is all anecdotal. We don't really know when to use it. It's an experience thing. Some people never use it and they say they swear by it. Others use it all the time. They swear by it. So I think it's an experience thing that you just have to come up with on your own.
Yep. Absolutely. I mean, I started using it, but then I stopped using as much laser once, we got Rotarex, but I definitely was using EPDs. They're just because of anecdotal, right? You get some anecdotal cases that go like that, then you change your practice.